So the title of my talk today is a novel approach to crowdsource the detection and management of large-scale cholera outbreaks. There's a lot of discussion about what the word crowdsource means, and we can actually get to that maybe at the end of the talk. But strangely enough, I'm not actually going to use that word, except for once, for the rest of this talk. This story begins back in basically 1994 in Goma, Zaire, which it was called at that time, in which 50,000 cholera patients died. And this was during a large refugee crisis. And there were a lot of reasons why so many people died. One of which was that Western physicians like myself, who are used to a certain scale of patients, were suddenly in a region in which they're dealing with thousands of patients, and the system became overwhelmed. And cholera, for those that don't know too much about it, we'll go into a little more detail, but it's a bacterial disease, and from time of infection to time of death, it's pretty much the fastest killer on the planet. The viral causes that you see in the movies, those have incubation periods, but this you can go from basically contraction in the afternoon and dead at noon the next day, with roughly 20% mortality. And when treated with oral rehydration solution, or ORS as I'll call it today, mortality rates are less than 1%. So I was a part of a project in 2005, 2006, in which we were trying to figure out a way to accommodate for this lack of knowledge on how to manage large-scale cholera outbreaks. And our basically mission was to take what we do very well in Bangladesh, which is we can treat 500 to 1,000 cases of cholera during the daytime, well, day and night, and export that level of expertise from a place like Bangladesh to an emerging outbreak like Goma or Zimbabwe or Haiti. And so we packaged, in essence, together the public health, the clinical, and the basic science of these cholera outbreak management kind of skill set into something called the COTS program. And in this project, we wrote it like a play. So there's, in essence, 15 or so key characters that are important to managing an outbreak. You need the cleanup person, you need the transport person, you need the security person, you need the nurse, the doctor, the pharmacist. Each of them have a unique job description. And working at scale means that you empower everyone in that play so that it's not hierarchical, but more on the same level, so that everyone feels capable of raising their voice when something's going wrong. That make sense? Okay. So we did a decent job at distributing this product. I would say the limitations of this were actually more on the marketing side than the actually product design side, because when we have used it, it's been very successful. But I still get emails saying, "Oh, we've been 2 months into an outbreak and we just heard about the COTS program," which is frustrating. But basically, despite efforts like the COTS program, if you go to settings like Bangladesh in the upper left, I have a pointer somewhere. I'm not sure it really works. Well, bottom left is Haiti. Middle is Zimbabwe, and on the right is a gentleman who died in the area I was working in, Port-au-Prince. So 3 gentlemen on the left I took care of, the one on the right I didn't. But each of them basically visually demonstrate that despite things like the COTS program, we're still absolutely failing at outbreak response, especially in the first month or 2 of outbreaks. So I want to rephrase my title in what I would call more human-centered design thinking, which I begin with the phrase of how might we crowdsource the detection and management of large-scale outbreaks. So that takes me to this outline. I want to introduce basically cholera as a use case for human-centered design. I want to go through some of the science and what I'm now referring to as empathy work. Is there anyone from IDO here? No? Okay. And then in that empathy work, I actually want to do that in small groups. And then the third part, talk about my unique situation in Bangladesh. And since this is liberation technology, I make the third point, identifying and testing solutions to liberate patients from isolation early in disease. And I want to keep mentioning this word isolation because I think in your careers you're going to have very different projects. But if you work, especially with underserved individuals, a key theme across that space is the word isolation. Okay, so these are the leading causes of childhood death, and this graph is for children less than 4 years of life. And they've split the data for basically to 1 month, and then 1 month up to 4 years. And this box, is it okay if I stand in front so I can point? So this box basically says that in 1 month to 4 years, diarrhea is the second most common killer of children, and then respiratory disease is the number 1 killer. But they're actually dependent upon each other. Basically, if a child has diarrhea, they are more likely to get pneumonia 2 weeks subsequently. And in addition, if a child has pneumonia and they had diarrhea 2 weeks previously, they're more likely to die of that pneumonia. So there's a link actually between those 2 top killers. So if you just work on diarrhea, you're actually indirectly also helping to address some of the pneumonia issues. So this is a very typical outbreak curve for cholera, but actually you can take the same curve and put it at earthquake victims in Haiti or tsunami victims in Indonesia. This is Haiti for the first 2 years of the cholera outbreak. This line right here is a 1% case fatality rate on this right y-axis, and that's a number of total cases on the other y-axis. So basically in WHO talk, anything above this black line represents failed response because the threshold is less than 1% for case fatality rates. So as you can see here, there's a lot of data above that black line, and that represents an opportunity as well as a challenge for intervention. And this is what's called a emerging outbreak, where the population is immunologically naive, in which they haven't seen the pathogen before. So it's like having flu without your flu shot. So this is a similar set of data, except for in a table format. And this is from Bangladesh, in which they've had cholera for centuries. Everyone has immunologic memory. But yet, there are parts of Bangladesh that still have case fatality rates above this 1% threshold. And we don't really know why this particular part of Bangladesh has such high case fatality rates, but it persists. And it's an ongoing problem that I want to help address. So presumably, many of you have taken an introductory biology course, I hope. So we're going to go a little bit into the biology of this disease. And I tend to do it like an epidemiologist, and I use their phrasing. So in epidemiology terms, H are new entrants into a population of susceptibles being S. So these are people that can get the disease, sort of like you without getting a flu shot. If you get sick, you become either symptomatic or asymptomatic. And then depending how sick you are, you may exit the loop as M for mortality, or you may enter a recovery pool. And then as a function of your immune system and other factors, you'll move from that recovered pool over to the susceptible pool over time. These patients shed cholera, and they shed cholera in what's called a hyperinfectious state, and it's 1,000 times more infectious coming out of a patient than it is out of water out of a test tube. And then this little symbol represents phage. These are little viruses that can infect and kill the bacteria. And outbreaks are thought to accelerate in part because of these hyperinfectious organisms coming out of patients and going human to human. And then outbreaks are thought to be quenched by these little viruses that prey and eat the bacteria. There is an environmental form to stage of transmission, but in time, the environmental forms and then the hyperinfectious forms can infect the susceptibles. Questions about this model? No? It's I mean, maybe I did a good job explaining.
So people that get well, where do they exit the body?
So they're basically in the recovery pool. And in time, they'll enter the susceptible pool, but if their water and their sanitation is good, they may never get exposed again. So this brings another model, which is basically, I think we think of cholera as being a waterborne disease, but there's a transition point in which the infection becomes waterborne to then being more human-to-human transmission. So an example would be a child goes out and plays in a river, drinks bad water, comes in the household, gets diarrhea, starts contaminating the food in the household, and all the siblings get sick. And so in general, I think of the water part of an outbreak being more of a linear event. And then once things go human to human, it goes exponential. And you may not know this human to human aspect of it, because in many ways governments don't want it to be known, because there's a large fear associated with these outbreaks. And once you start talking about human to human transmission, people get very scared. But if you want to talk about interventions, this inflection point is where we need to be, and where basically historically we've never been able to be. And that inflection point basically relates to that model I just showed you, which is this relationship between environmental versus human source. So as I mentioned, there's an opportunity basically for intervention at this point, in which we can ask, how might we better identify household index cases, provide support at the level of the household, and also stop transmission. And this is, this has been sort of the dream of not just cholera scientists, but the infectious disease community for many years. And the CDC, as much as they like this talk, they've tried similar things in the past, but they've never really leveraged mobile technology to see if they can start working at that inflection point. So in essence, the science of this problem is that the biology of the disease of cholera transmission and pathogenesis outpaces our technical ability to track and intervene. And at least in my line of work, I like to put my thoughts together in a hypothesis format. And so the hypothesis that I'm working with is we hypothesize that mobile technology at the level of the household may make it possible to identify cases earlier, provide better care, and better understand progression and transmission. So I went to Terry's office, I don't know, it's a while ago now, and I was doing what I would call solution-centered design, or principal investigator-centered design, which is I sit on a campus here in Palo Alto, and I stare at the whiteboard, I talk with people, and I try to come up with a solution. And then you go out to the field, and you test it, and you typically fail. So I showed up to Terry's office with this graph, and I wanted to get some feedback on it. And what I was thinking was that in our existing system, we have patients in the community that get sick. They come into triage. We use pencil and paper epidemiology. This sets basically the standard for response. The types of cases we get are more the severe patients, and then also sets the standard for what quality of data that we have. So I was dreaming up, well, you send someone into the community with a handheld device. They'll be in the community, so it's a little bit faster in terms of being in the community versus in the hospital. They're entering the data in real time, so it's a little bit faster in that regard. But you're still going to probably be capturing the moderate and severe cases. And even though the data is directly has direct input, and the speed is a little bit faster, there are still limitations. So then I was thinking, well, how do you get the community to basically text in, I have diarrhea, which sounds ridiculous, right? Who's going to say, hey, look, I have diarrhea today. I didn't have it yesterday. But that's sort of where my thoughts were coming from. And in this case, if the community does that, you may get data very quickly. If you're in a community like Haiti, where everyone that has diarrhea thinks they're going to die by the morning from cholera, the quality of data could be quite low. But it's possible that you capture more of the mild cases. So I had a lot of ideas in this table, but there's a lot of thinking to be done, which takes us to moving from the principal investigator perspective over to the patient perspective. So let's go back to these 3 patients. And I want to do a little bit of a breakout session where it's one thing just to have your patients come to you and do a brief history. It's another thing to sort of get inside of their heads and figure out what happened yesterday, what was happening at night, and what happened this morning. What was your knowledge of the disease? What were the barriers for you to seek help? When did you think about seeking help? And how much time did it take to go from that juncture of wanting to seek help to actually being in the clinic? So that's a really important question, and you think it would have been asked and studied in great depth, but it hasn't been. So we're going to go into something I've been learning about from this group IDEO. I think that the D School preaches this, but it's relatively new to me. So as I enter this design challenge, I rely upon my colleagues a lot. So a good design in IDEO speak is one that has desirability, feasibility, and viability. So it needs to be desired by the mom in that household. It needs to be feasible in terms of the cost of providing wheelbarrows to everyone in the bush. And then it needs to be viable from a sustainability and business perspective. And then this graph I go to frequently, which is basically 3 phases of the design work, which is basically hearing phase, in which we're doing what we're doing now, which is empathizing with that mom in the household, going into a creating phase, and then lastly a delivery phase. And along this curve, the reason why it's a curve is that you begin sort of at a concrete level of thinking, you abstract, and then at the end you come back to implementation. In the very beginning, scientists like myself and physicians were not super comfortable with, in which we're going to qualitatively gather observations, make these into stories, themes, identify opportunity solutions, then prototype and implementation. I'm trying to write a grant right now, and it's very hard to get the NIH to understand how important this is, because it's, for whatever reason, it's sort of new to my field. So we have the benefit of working in a pilot site called Basta Union. This community has 30,000 individuals. It's right outside the city of Dhaka, which is about to be the 3rd largest city in the world. We're leveraging an ongoing vaccine project in which every household cluster has a GPS location. We know the socioeconomic data of every household. We have every household member with a unique identifier. We have the cell phone numbers for half the households. In this community, there's roughly 300 cases that come into the hospital of cholera, and that's just a small fraction of total diarrheal cases. And then also, if you do the math and you back calculate, there's probably 1,200 cases in the community in a year, meaning 900 don't come to seek care. This community is a typical kind of semi-rural community. It's built up on dikes because it floods during the rainy seasons. It's very industrious. This isn't the most poor community. I would say it's kind of poor to lower middle class, actually. And when I've done the limited work that I've done so far, the story basically comes back to this woman, where I alluded to her story a little bit earlier, that she basically said, and this is what you will do. And she sat us down on little stools, and she explained her experience at night, sort of like what I was trying to get you to empathize with a few moments ago. And again, she said, I have 4 kids. I can't leave the house. If my kid falls ill, I'll use ORS as much as the child will take. And I asked her, oh, do you have ORS in your medicine cabinet right now? And she said, no. And I said, well, what are you going to do? And she's like, well, ask my neighbors. And all her neighbors were around us in this picture. And they all said, sorry, we don't have any in our house either. So I said, well, what do you do if you don't have ORS? And she said, well, I'll wait till the morning when the pharmacy opens. So there began to be a common story that emerged from this conversation and many conversations like it, both in the community as well as the patients at triage in the hospital, which there was this gap between 10 p.m. when pharmacies closed and 8 a.m. when the pharmacies opened, in which moms like this were on their own. So you can start to see sort of an opportunity taking shape. So then we wanted to go to the other side of the story and talk with some pharmacists. And again, we sat on stools. we stood at a lot of counters in local pharmacies, and they said, during the daytime, we don't need your help. Not only do we have lots of drugs, but we diagnose as pharmacists, we prescribe drugs. If a severely dehydrated patient comes in, this is a bag of actually cholera saline, this is IV solution. They'll actually put the IV in and rehydrate them in the pharmacy. In the afternoons, doctors come to that pharmacy and provide care. And they said, but we do close at 10 or 11. I have a few family friends that have my cell phone. They can call me if they need me to open the pharmacy. So we went back and we did, I think what's common in the design world is you start putting all of your ideas on little pieces of paper, and you keep shuffling them. And you throw the bad ones on the ground, and you keep shuffling and writing new ideas. And this is an ongoing process. But at some point, what now seems obvious was basically a night delivery system for oral rehydration solution. Questions so far? So when I created this graph to show you where I'm at in this project, I wanted to put a vertical line to say this is where we're at. But basically I had to put a horizontal line because it's not a clean process. You march along the x-axis and then you keep having to go back. And so we have sort of marched this far and then we fall back, we march and we fall back. So I want to show you sort of where our workflow is right now. So at the top is basically the mom at home at nighttime. And there's actually another box above that, which I don't have on the slide, which is that we want to basically canvas this community saying there's an ORS delivery service with your local pharmacy available at night. Call this hotline number. And then this mom will have that card in her home. And then our thoughts are that she can call the hotline. And we basically want to be working with pre-emergency patients. We don't want to let patients become emergencies because then once they're emergencies, they may die within 30 minutes with cholera. So we specifically want to have the first message be, if this is an emergency, hang up and go with the standard of care, hopefully being your closest open hospital. That's a big question in our project that we're working to answer. But that's the first level of triage we have to try to select for the pre-emergencies and the emergencies. And then we can't possibly ask pharmacies to stay open 24 hours a day. So you want to have basically an on-call pharmacist for each night, and then have an on-call delivery service for that pharmacy each night. So with a little kind of background computing, we'll roll the call to the open pharmacist. And then we know that even pharmacists there's a large spectrum of experience and training. And so we know that some of them need to have some decision support. So we want to provide them with a smartphone. Most of them actually have smartphones, but basically guide them through the algorithm on how much fluids per how many hour an infant of 6 months or 14 months should be taking to not only advocate for ORS, but make the delivery better. And then the question is, how are they going to get the ORS? They could come into the pharmacy if there's enough business for the pharmacy to actually keep the doors open. You could have a delivery to the household. If the community is flooded, what's possible is you have meeting points where the driver and maybe a family member goes to that meeting point. But you can see, even in this workflow, you're probably having lots of little questions of, what about this? What about that? There's endless questions that we're going to be hoping to address, most of them this spring in some design work. And then another loop on this is that the delivery person has a great reason to charge more for the service they're about to provide. So we want to have a callback loop, which is in an hour, the server calls back and says, did you get your ORS at the right price? If not, do this. And then for our study purposes, we're going to have multiple safety measures in this. So Nancy here and I and a couple other people, we're writing a grant right now on this. And it's very challenging. And it's because we want to bring to the mHealth field, this mobile health field, outcome measures that are rigorous at the level that we do with the rest of the NIH level research. And it's very challenging. So in our aim 1 right now, we basically want to have the assessment of the design basically from the perspective as a public health intervention to identify cases early in disease, provide ORS at the household level. So what I mean is that we have the workflow that I just went through, and we're going to detect number of cases. And then we also have an ongoing surveillance system at the hospitals that detect cholera cases and total diarrheal cases. So we can basically look at the incidence by cases detected, be the standard versus our system, and hopefully would detect more cases with our system than the standard system. If we don't, we have a fundamental design failure, and we have to go back and make sure that our monitoring and evaluation picked up where that design failure happened. And also, cholera, the dehydration from cholera is assessed in mild, moderate, and severe, 3 categories. So we'll have those data from the hospital surveillance, and then I'm going to provide a nurse who will do that assessment with the delivery person so that we can gather data and that hopefully would detect more mild cases at home than just severe. Because if we're only detecting severe ones at home, we also have a design failure. Questions about this aim?
Yeah, I'm just curious because you're counting it in terms of detection, but if you're providing the salts, you're actually going to have an effect on mortality or morbidity.
Yes. So the question is, should we also basically consider this to be an interventional study in which we're intervening by pouring ORS in that household, and are we saving more lives? We may do that. It makes the clinical, the grant work basically more complicated, sadly, because you have to have a point of comparison, which I have to do more on this side of the figure. But that's basically where we want to go. Yeah.
I have a quick question about the previous slide. If it's an emergency and you're saying go to the hospital, what is the difference in treatment? So if you have an emergency patient in the hospital, what is it the same?
So there's either IV fluids or oral fluids. If you're severe, that means that you're unconscious and you need IV. If you're, let's say, mild or moderate, but you're having a lot of vomiting, then you need IV. So it's more likely to get IV therapy at the hospital.
So IV can't be self-administered?
No. Yeah.
So cholera treatment, is that the treatment plan? And is it another dehydration?
Yeah, so that's a good question. So do you need antibiotics to survive cholera? It's always interesting when you ask doctors working in outbreaks if they would take antibiotics if they got cholera, and they all will say yes. But the data are that you don't need it to survive, but the antibiotics basically cut the duration of symptoms down by half, which if you're running a huge outbreak hospital, that means you have twice as many resources available to you if you use antibiotics. So we use antibiotics for the severe and moderate cases. But at the household level, they're mild, they don't need antibiotics. Yep.
Two questions that are related. First is with the driver that's delivering the ORS,
Mm-hmm.
how far would their starting point be from the pharmacy that the community would be able to purchase ORS supplies at in the daytime?
That's a good question. So the question is, what's the proximity between a house in need and the driver?
No, I'm actually talking about the other end of the component. Is the driver starting out at the pharmacy?
Oh, good. Yes. So basically, is the driver stationed at the pharmacy for the night, or is a driver asleep at home, wherever it may be, and then has to go to the pharmacy and then go? That is a good question. I don't know.
Or is he like pre-stationed closer to the community in need with a truck already loaded and ready as necessary?
See, you guys have great questions. I don't know yet.
And that leads to the second question. If he's stationed close to the pharmacy, would it be possible to basically bundle the physician into the driver role, that you have the pharmacist be the driver, and so administering IV is a potential solution?
So you ask a collection of good questions. My response to your questions is a function of if I want to scale this project or not. Because I can do a small scale pilot and pack that CNG, that's an auto rickshaw with doctors and IV bags and everything. But if you want to scale this beyond my pilot site in which you create a business model in which pharmacies are providing a service at night that the households need, it has to start to function on its own without me providing money into it. So it's a function of the scale.
And just an alternative I was thinking, because maybe if you want to scale it, driving doesn't seem the most scalable either within these economies and within the infrastructures. But maybe I was just wondering, like, maybe you're having a central station, and instead of serving, I don't know, like 10 kilometers away, you could serve maybe up to 100 if you, instead of having drivers use drones to deliver. I mean, and
well,
just drop off the ORS and then have the drone go back.
So I don't know if you guys heard the word drones in there, but that's actually really important because when you go into a design session, the factor that's important in the success of that design session is how creative you are. So we do something that's silly, which we always incorporate crows into our design, where we try to have some sort of solution that involves crows. So you can train crows, and something as crazy as training a crow to detect the wrappers for ORS packets. We're thinking, oh, you send out the crows, they bring back X number of wrappers, you know where you're at in Outbreak. So it's, I'm not actually making fun of the word drones. I actually think it's really important that you bring up an outside-the-box idea. So I'm going to motor through a little bit more, and then we can answer more questions. So I want to move from this, which is looking at this question of what are our outcome measures in terms of the most basic things. Did we detect more cases? Did we detect more mild cases? To something that bridges over to science. Because you could do, even at this level, start doing interventions. You could start giving this individual antibiotics. You could start wrapping them in saran wrap to protect them from other kids. You could start, there are all kinds of interventions you could do at the household. But you'd be surprised actually at how little we know scientifically about what's happening in these households in terms of transmission, because we've never had a way to get into the household, collect samples, and study transmission from the early point in disease. What we do is we wait for the patients to come in after their bodies and their microbiologists failed to protect them from the disease, and then we go back to their household, which is a day or two lag, which means that the household contacts are probably all infected. So before I want to do interventions, I basically want to understand the science a little bit better. And so we now can basically do this, where aim 2 of this work is that I want to assess the design of this project basically as a tool to better understand the disease before interventional studies. So for example, can we identify microbial correlates to both the progression and transmission of the disease that are independent from ORS? Because we'll study this, but hopefully I get ORS into all the households and they're all taking it according to the instructions. That probably won't be absolutely true, but I hope it's the case. So what do I mean by correlates? So there are going to be index cases that get sick, and there will be index cases that have co-infection with another pathogen, Montezuma's revenge or traveler's diarrhea. It's called ETEC. A third of cholera patients in the hospital are co-infected with ETEC. And we don't know what that means in terms of their disease progression or transmission. Also, a third of the patients are co-infected with a pathogen, a spirochete of pigs that's only been described in the Midwest. But a third of my cholera patients have those. So we can ask the question of, if you're co-infected with cholera plus something else, are you more likely to progress to a more severe disease state, even if you're taking all your ORS? And also, your household contacts more likely to get sick compared to someone that doesn't have that co-infection, that just has cholera. Are they actually going to get better, and is there less rates of transmission? So we can start to delve into questions of correlates that are really important. There's a multi-million-dollar vaccine trial going on in Bangladesh, and the outcome measures for that vaccine trial are, if you were vaccinated, did you get sick or did you not get sick? But we're only detecting those patients when they come into the hospital. We're not detecting them at the level of the household. So a study like that has a lot more statistical power if you do it with this sort of household level detection. That's a lot of kind of stats I'm mentioning, but I'm trying to show you that there's a window of science that's important just for knowledge's sake, but also for when you design interventions. Okay, so it is 5:37. I know some of you have a 5:30 seminar. So basically, where have we come from? I hope that I've showed with you basically that cholera, for me, is becoming a use case for human-centered design. I shared with you a little bit about the science, a little bit about how to do empathy work, getting inside the heads of the mom at 2 in the morning, and then going through this process of identifying opportunities and solutions for intervention, and in our case, liberating patients from isolation at nighttime. So for those that think this project is completely crazy, let's take a lesson from TaskRabbit. So I don't know if you saw this, on January 7th, Walgreens has launched a collaboration with TaskRabbit that if you're tonight homesick at 2 in the morning with the flu and you forgot to take your flu vaccine, you can press the wheel on TaskRabbit and it will connect you with a TaskRabbit to a 24-hour pharmacy that will get you flu medications tonight. And I thought this was great, because I'm wanting to do exactly this, but with the poorest, most unrepresented people on the planet. And I think it's going to be fascinating, because we're going to come from both ends of the spectrum towards each other. Oh, and we'll see what happens. Okay, so last thing is my acknowledgments. For this line of work, it's really important to have a diverse team. And I kind of alluded to this, but you can't do this in the silo on the medical campus. I've had help from Terry. I've had help from design people up in the city. I've had help from technology people, as well as my colleagues in the field. The strength of this effort is not only a function of creativity, but also the diversity of your team. So I have that here and in Bangladesh. We're doing this under the umbrella of the Ministry of Health, because you don't want to have a fractured initiative, and you also want to have an initiative that can be scaled. So if we do it within the ministry, hopefully we achieve both. And then this project is funded by a group called the Center for Innovation and Global Health on the medical campus. Okay, thank you.